Hi, my name's Belinda Welsh, dermatologist and director of Complete Skin Specialists in Sunbury, Victoria. Every April is Rosacea Awareness Month, and leading into the month, I wanted to take a few minutes out of your day to talk about rosacea, its common signs and symptoms, and how to identify rosacea among the more common facial skin conditions you'd see every day in your practice. Rosacea is recognised as a chronic, inflammatory, relapsing and remitting centrofacial syndrome. Patients of any skin type or ethnicity can be affected, but most commonly, people with fairer skin types tend to present for treatment. Flushing can start at any age, but I most commonly see it presenting from 30 years onwards. It affects men and women equally, but women tend to present more often for treatment. Its etiology and pathophysiology unfortunately remain incompletely understood. We've got no histologic or serologic diagnostic tests, so clinical acumen remains really important in recognising it. Despite this, the good news is that it's extremely manageable. The most recent classification recognises two primary diagnostic features. The first is fixed and transient erythema, or redness and flushing, in the central portion of the face. That is, the convexities of the nose, cheeks, forehead and chin, lasting for about 3 months. The second is the formation of phimers, which is hyperplasia or thickening of connective tissue. The most recognisable phimer is rhinophyma, or thickening and enlargement of the nose, which is most commonly seen in men. Other characteristics which are often present include telangiectasia, inflammatory papules and pustules, edema, burning, stinging, or skin dryness. It's very important to remember to inquire about eye symptoms. Ocular involvement can occur in up to 60% of rosacea patients. So traditionally, rosacea has been grouped into 4 subtypes: erythematotelangiectatic, papulopustular, phymatous, and ocular. These signs and symptoms can sometimes overlap, so they're not necessarily distinct clinical groups. Patients often present with a range of features that span multiple subtypes or may progress between them. So today I want to concentrate mainly on erythematotelangiectatic and papulopustular rosacea, because in my experience these subtypes can often be misdiagnosed with the papules and pustules of acne vulgaris. Here on screen we see an example of erythematotelangiectatic rosacea characterised by flushing and vasodilation alone. Eventually, this erythema may become permanent and telangiectasia can develop in the affected areas, which is commonly the nose, cheeks and chin. Sun damage often contributes to this phenotype, and patients can be very self-conscious about their appearance. Papulopustular rosacea is another common subtype I see in practice, and as you can see, this is characterised by persistent and episodic development of inflammatory papules and pustules, again in the central face. Some patients you see may present with all of these features. One question I'm often asked is how to differentiate acne from papulopustular rosacea. The key feature to look for is comedones, otherwise known as blackheads, open comedones, or whiteheads, closed comedones. If there are comedones present or larger cysts, you're dealing with acne, and topical retinoids are an appropriate treatment. If no comedones are present, you're more likely dealing with papulopustular rosacea, and this can initially be treated with topical ivermectin or metronidazole. Some other skin conditions share features with rosacea. Seborrheic dermatitis, for example, presents with facial redness, but scaling is often a prominent feature. It tends to involve the medial cheeks, the eyebrows, the nasolabial folds, the scalp, where we talk about dandruff, and pre-sternal areas. Keratosis pilaris rubra can be difficult to differentiate from erythematotelangiectatic rosacea, but the key here is that there's fixed, well-defined geographic flushing on the lateral cheeks rather than rosacea, which is centrally located. The lateral cheeks in keratosis pilaris often feel rough due to these very small keratotic plugs. So another tip is to check the lateral upper arms, which is also very commonly affected in keratosis pilaris. Papulopustular rosacea can initially be treated topically with products such as 1% ivermectin, more commonly known as Soolantra. This is a once-daily cream that acts partly by reducing excessive numbers of Demodex mites that reside in the hair follicles of people with rosacea and results in reduced inflammation. Alternatively, metronidazole or Rosex is a twice-daily cream that works via anti-inflammatory mechanisms. So, my overall management approach to rosacea includes 1. A simple skincare regime with daily SPF sunscreen, gentle cleanser and moisturiser. 2. An active prescription topical, either 1% ivermectin or metronidazole cream. 3. Oral antibiotics such as doxycycline, 50 to 100 milligrams a day for 2 or 3 months if needed. And 4. Vascular laser for the background telangiectasia, erythema and flushing, and this is important. So to sum up, rosacea is common but very manageable. Patients can present with more than one subtype of rosacea, and don't forget ocular involvement. If you've got a patient with papules and pustules, the presence of comedones suggests the diagnosis is acne rather than rosacea. If your diagnosis is rosacea, the papulopustular component can initially be treated with topical metronidazole or ivermectin creams. So this April, Rosacea Awareness Month, I strongly encourage you to speak to your patients about their skin and let them know that their rosacea can be successfully treated with the aim of clear skin.